Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Occupational English test. Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. Tell me, what's your problem?
Well, I have a 9-year history of occasional palpitations. Symptoms occur 3 to 4 times per year and they last for an hour or more and my heart beats more rapidly, but I've never measured my heart rate. The most recent was yesterday. It's associated with feeling of darkness descending as if a shade was being pulled down in front of my vision. However, I don't lose consciousness yesterday while working on a computer. I had a spell. Palpitations persisted for a short time.
Okay, what's your age?
48, doctor.
Do you smoke or drink alcohol or use caffeine?
No, doctor.
Is there any family history of congenital heart disease?
No, doctor.
You had any history of thoracic trauma or thyroid disease?
No, doctor. I had anterior cruciate ligament reconstruction complicated by contact urticaria from a neoprene cast.
Are you taking any medications?
No, doctor.
Are you allergic to any medication or substance?
Yes, I am allergic to neoprene.
As per your physical exam results, your pupils are reactive sclerite and nitric mucous membranes are moist. Neck veins not distended. No bruits. Lungs are clear. Cardiac exam is regular without murmurs, gallops or rubs. Abdomen is soft without guarding. Rebound masses or bruits. Extremities well, perfused. No edema, strong and symmetrical distal pulses. AD dimmer was mildly elevated to 5 CT scan showed no evidence of pulmonary embolus. Moreover, there is no progression over the 9-year period that you have been symptomatic suggests that this is an unlikely cause. 2-dimensional echocardiogram shows no evidence of clinically significant structural or functional heart disease. A 12-lead electrocardiogram shows sinus rhythm with normal axis and intervals. No evidence of a pre-excitation. Lab reports show no evidence of myocardial injury. You have episodic palpitations and presyncope. I would suggest outpatient workup. Event recorders should be obtained and I will see you again upon completion of that study. I will prescribe suppressive medication, beta blocker, or Cardeza. There will be symptomatic improvement of the disease through it.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes. John, please come on in and have a seat.
Thank you.
From what your primary care physician shared with me, you've been having an issue with your right foot. Is that correct?
Yes, that's right. I visited my GP about a month ago because I've been experiencing persistent pain in my right foot. It's been on and off for a few years now, but recently it's been more frequent. This pain, it's right here on the heel. The area's a bit swollen at the moment, but it was worse a few days ago. My doctor wasn't certain what could be causing it, so she referred me to you. She also took an X-ray. Did you receive it?
I did, yes. Can you tell me a little more about the pain and when it usually occurs?
Well, I can generally sense when it's about to get worse because there's a slight tingling sensation, almost like pins and needles. Then, within a few hours, the pain hits. It feels like a deep, throbbing ache, and the area around it usually turns red and swells up. My doctor said it looked quite inflamed. Over time, the swelling decreases and the pain eases off. It tends to leave a slight tenderness though. Right now, you can see that it's not as swollen but it's still tender.
I see.
This has been happening for a few years, ever since I was working abroad in Brazil in the early 2000s. Initially, I also had similar pain in my left foot, but that hasn't recurred. However, the pain in the right foot keeps coming back every few months, but it's never in the exact same spot. I thought it had resolved itself when I didn't experience it for a couple of years, but then it returned. There's no clear pattern, it doesn't get worse or more frequent, and I haven't been able to link it to any particular activity or stress levels. The GP thought a specialist should check it out, especially since I had a case of plantar fasciitis in the past which was treated successfully.
Okay, well that's helpful. Let me just examine your foot. Was the plantar fasciitis in this area?
Yes, exactly there.
All right. Everything appears normal there. I don't believe you should be too concerned about this being a serious condition. Do you happen to experience any gout symptoms?
No, I've never had any. I did consider if this could be related to gout, but I'm not sure. I wondered if you could suggest a medication to help manage the pain.
Yes, medications can help manage the symptoms, but they might not treat the underlying condition causing the pain. The skin on the foot is also relatively thick, which could reduce the effectiveness of some topical treatments.
I see. I've also been concerned about possible infection. Should I be keeping the area covered?
No, not unless there are open wounds. It should be all right.
All right. The pain hasn't really affected my daily activities. It's just a nuisance I've been living with all these years.
Okay. So, you mainly visited the doctor to see if we could find a way to prevent these episodes. The next best step would be to arrange an MRI scan. It might be a bit uncomfortable, but it will allow us to rule out certain conditions.
Okay, that sounds fine.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, Choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Mr. Wilson was admitted yesterday due to chest pain. He arrived with symptoms such as palpitations, shortness of breath, and intense chest discomfort. He is a 70-year-old gentleman with a history of type 2 diabetes and a pacemaker implantation 3 years ago. His diet is low sodium and he's allergic to penicillin. His condition necessitates a low-level activity, as exertion could exacerbate his symptoms. We've started him on nitroglycerin, which he seems to respond well to. His examination is fairly routine, other than a slightly elevated blood pressure and heart rate. His vital signs are now stable, oxygen saturation is 96% on 2 liters, and he has been generally cooperative during my shift. At about 4:30, I administered 1 tablet of amlodipine for his high blood pressure, with significant improvement. He has a 20 gauge in his right arm. He's got dextrose saline at 10 mL per hour.
Now look at question 26. Let's talk about the immunization procedure. I am delighted to see everyone so diligently following the new protocol, and because of this, vaccination errors, which were already low in our department, have further decreased by 30%. The data we've gathered show some surprising trends, like errors being more frequent in the afternoon than mornings or evenings. We don't have a definite reason for this yet, but the pattern is quite noticeable. Also, we've noticed that disruptions during the vaccine preparation phase are a common source of errors. So, please do your best to not distract your peers when they are preparing doses. Lastly, we should always be vigilant for any adverse reactions, contraindications, and patient-specific issues. Thankfully, we haven't encountered many issues, but as we all know, pediatric care often involves multi-layered complexities. Now look at question 27. Let's discuss the patients that were admitted overnight. Alex, can you start?
Certainly. We have Bill Thompson in room 7. He's a 70-year-old male who was transferred from the ER last night. He has a history of lung cancer and presents with increased breathlessness and a persistent cough. He's to stay under intensive care until his symptoms stabilize. We'll be monitoring his vitals every 30 minutes, paying close attention to his respiratory rate, oxygen levels, and the efficacy of the interventions.
All right. I'll check on his clinical status later this afternoon. What's the discharge plan?
A consultation with a social worker for post-discharge care and community support has been scheduled for the day after tomorrow. There's also the possibility of appointing a healthcare proxy if necessary.
Okay. We'll discuss that in more detail during tomorrow's meeting. Now look at question 28.
Mrs. Sanders, what brings you in today?
I'm hoping to change my diet.
All right. Are you considering a specific diet plan?
Yes, I've been researching the Mediterranean diet. I had my first child recently, and I want to adopt a healthier lifestyle to set a good example. But I'm worried about completely giving up my favorite snacks. Can I indulge occasionally?
Moderation is key, so an occasional treat is fine. However, the focus should be on consuming more fruits, vegetables, whole grains, and lean proteins.
That sounds reasonable.
And you mentioned some postpartum anxiety after your childbirth?
Yes, it was quite a difficult period. It didn't last long, but I want to be better prepared this time. I've read that a healthy diet can help with mood stabilization.
That's absolutely right. A balanced diet can certainly contribute to overall mental health. We can work on a meal plan that aligns with your goals.
Now look at question 29.
So, how was your day, Emily?
I must admit I ran into a bit of trouble with Mr. Johnson's catheter. I've done the procedure multiple times now, so I felt confident. However, I didn't anticipate the difficulty I'd encounter with the insertion. It seems his enlarged prostate made the procedure more challenging.
That can occur with older male patients. It's important to ensure the procedure is carried out swiftly and accurately to minimize discomfort.
Indeed, he was incredibly patient throughout the process. I'm not sure I would have handled it as well.
That's all right. Next time, let me know and I'll be there to guide you through it.
Now look at question 30.
So, I understand you've had this cough for a while now, correct?
Yes, it started after I came back from a camping trip. My mom thinks I caught a cold.
You do have some congestion, but I don't believe this is a simple cold. Does it hurt when you cough?
It's more itchy than painful, but it gets worse at night.
I see. It sounds like you might have what we call post-infectious cough. This is a common condition after a viral respiratory infection, and it can last for several weeks. But to be sure, I would like to order a chest X-ray to rule out any lung condition, and we can discuss the results once they come back.
Oh, all right.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Today we have the pleasure of speaking to Dr. Emily Patel, an oncologist and expert on pancreatic cancer in the USA. Dr. Patel, could you please explain what pancreatic cancer is and why it is often referred to as a silent disease?
Pancreatic cancer originates in the pancreas, a small organ located behind the stomach. Its primary function is to secrete enzymes that aid digestion and hormones, such as insulin, that help regulate the metabolism of sugars. Pancreatic cancer is often called a silent disease because symptoms do not usually appear until the disease has reached an advanced stage. Most cases are detected late, which makes treatment more challenging and significantly lowers survival rates. It's the third leading cause of cancer-related deaths in the United States, surpassing breast cancer. Pancreatic cancer receives relatively little publicity or research funding, partly because of its low incidence and survival rates.
Interesting. What are the main risk factors for pancreatic cancer?
The primary risk factors for pancreatic cancer include smoking, obesity, age, and a family history of the disease. It's also more common in people with diabetes and chronic pancreatitis. Unfortunately, because symptoms don't usually present until the disease is advanced, it often isn't detected until it has spread beyond the pancreas. That makes early detection and prevention efforts critical.
Could you provide a real-life example to illustrate what pancreatic cancer patients typically go through?
Sure, let's talk about a patient of mine we'll call Tom. Tom is a 65-year-old man who came to see me because he had been experiencing unexplained weight loss and jaundice, a yellowing of the skin and eyes. He was previously healthy and active, so these symptoms were quite concerning. After a series of tests, we confirmed that Tom had stage 3 pancreatic cancer. Unfortunately, at this point, the cancer had spread beyond the pancreas, which limited our treatment options.
What challenges are there in treating pancreatic cancer?
There are quite a few challenges. In Tom's case, like many others, the disease was detected late, which limits the treatment options. We started him on chemotherapy, but this treatment often comes with debilitating side effects. Plus, for pancreatic cancer, chemotherapy can help extend life and relieve symptoms, but it isn't typically curative. Surgery can sometimes be an option, but often the disease is too advanced by the time it's diagnosed. Another challenge is that we don't have a lot of effective targeted therapies for pancreatic cancer, unlike some other cancers.
Do you see patients with more advanced stages of the disease?
Absolutely. I have a patient named Linda who was diagnosed with metastatic pancreatic cancer, which means the cancer had spread to other parts of her body. Despite chemotherapy and other palliative treatments, her condition has steadily worsened. The best we can do is manage her symptoms and try to maintain her quality of life. Linda's experience underscores the need for more research and better screening methods for early detection.
What can be done to improve the situation with pancreatic cancer more broadly?
There's a lot that needs to be done. First, we need to invest in more research to better understand the biology of pancreatic cancer and develop effective treatments. We also need to improve early detection methods, which could significantly improve survival rates. Educating the public about the risk factors and symptoms of pancreatic cancer can also help people seek medical attention earlier. Advocacy and fundraising efforts can also go a long way in raising awareness and securing funding for research.
Well, Dr. Emily Patel, we appreciate your time and insights today.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42. Hi, good afternoon, everyone. I'm Sarah Thompson, a speech and language therapist here at our healthcare facility. Today, I'm going to walk you through a case study highlighting the nature of my work. But before we get into that, let's take a moment to discuss what speech and language therapy is all about and its critical role in patient recovery. In essence, as speech and language therapists, we work with patients across different age groups, helping them improve their communication skills and swallowing abilities. The patients we work with range from those who have speech and language issues due to conditions like stroke or Parkinson's disease, to children with developmental disorders such as autism. It's essential to remember that we are not just treating symptoms, but we aim to understand what our patient needs to communicate effectively or eat safely. While a doctor might ask, "What's the diagnosis?" my initial question is often, "What are your communication or eating goals?" Now, let's move on to a case study. I'd like you to meet James, a 50-year-old man who experienced a severe stroke. The stroke affected his speech abilities, rendering him almost mute and severely impacting his ability to swallow safely. When I first met James, after a week in the hospital, he was visibly frustrated and scared. He was not only unable to express his thoughts and feelings, but also at a high risk of choking when eating or drinking. The doctors had informed him about his condition, aphasia and dysphagia, medical terms that seemed distant and complex to James. James initially showed a bit of resistance towards therapy. Some healthcare professionals thought that if he was unwilling to participate actively, there wasn't much they could do. However, I held a different perspective. James couldn't speak, but he could still make sounds, and his cognition was unaffected. I decided to focus on what he could do, for instance, using different sounds to communicate his basic needs or to call for help. We also started working on his swallowing skills, ensuring that he could eat safely while reducing the risk of aspiration. The journey was challenging. We started with simple communication exercises, such as pointing at pictures or using gesture, and progressed towards producing sounds and syllables. We also worked on safe swallowing strategies, initially with a modified diet and gradually advancing towards normal food as his abilities improved. There were times when James would become disheartened due to the slow progress, but I constantly reminded him that his active participation in therapy would decide the quality of his life moving forward. That was a significant motivating factor. After 9 months of intense therapy, James had his share of victories and setbacks. He still struggles with fluency and has a persistent mild swallowing difficulty. Yet, he can now communicate his basic needs, participate in conversations, and enjoy his meals with precaution. His transformation has been inspiring. Today, James is back home and continues to attend his speech and language therapy sessions. His family's support has been commendable, encouraging him without hovering protectively. He continues to take charge of his recovery, practicing his exercises regularly, and maintaining a positive attitude. Observing such transformations makes me incredibly proud of the work I do and the impact it has on our patients' lives.